Let's talk about emergency medicine. You want to be an ER doctor? Let's see what ER doctoring is.
Drunk and disorderly guy? Get her down here now.
What is it?
Explosion at a power substation. Multiple burn and blast victims, 3 minutes out.
How many?
At least 8.
Make sure you clear the trauma rooms. Jerry, get the blood bank to send all their Oneg. And Dawn, make sure we have enough morphine and rapid infusers.
EIA.
You want to be an ER doc? This is the fun part.
Morris, triage.
55-year-old man thrown 20 feet against the wall. Diffused abdominal pain, BP 80 pounds.
Rigid abdomen, probably spleen or liver. Tracy,
Yeah.
2 of Oneg and hold for the OR.
Open femur, good distal pulses.
Now take this. Junie, yeah. Grab an ANSAP 100 a gin, titrate the Laudin, and call ortho. Julia, you're up for burn. I got Bardelli's rig. Good.
Found them down a V-tip on a high power line. Epi, lidocaine, 10 shocks, put them into a system.
Trauma 2?
No, curtain 3. We have to hold trauma for the ones we can save.
27-year-old male, short of breath, pulse ox 82,
come on.
decreased breath downs on the
No
right.
facial burns.
Pneumothorax.
Okay, set up for a chest tube.
Arm was blown off below the elbow, intubated up to 10 of MS.
All right, Sam. Anything to reimplant?
Bits and pieces.
Go. Carter, you working? Absolutely. Come on.
Burns over 90% of his body. Should have vocal cord.
Leaders of ringers, let's tell the burn service. Okay, go.
Dr. Green, you coming?
Tight wheezing throughout the right. Pulse ox 88.
Check for singed nasal hairs for smoke inhalation. Set up for intubation. 38-year-old man.
So, what is emergency medicine? According to the 2022 model of the clinical practice of emergency medicine, it's a specialty that's actually driven by symptoms primarily and not diagnosis, and it requires simultaneously both treatment and diagnosis. Okay, and from my point of view, after long-term practice, it's a specialty that contains all the knowledge, the skills, and the art of caring for all medical and behavioral emergencies. That's how I would sum it up. Now, the emergency medicine specialty began actually back in 1968 when ACEP, or American College of Emergency Physicians, was formed. And here's a little bit of info.
In the 1950s, advancements in battlefield medicine were brought home to America's hospital system. In the 60s, specialty training began, and emergency medicine was born. Join us for ACEP 18 in San Diego, where we'll celebrate the 50th year of ACEP and emergency medicine. We'll see you there.
Now, so I've been an instructor over at U of A, COM, Phoenix, for about 6 to 7 years, and met lots and lots of medical students of different grades, MS1 through MS4. And very, very often, this is a question, is the emergency medicine right for me? And that's a tough one. That's a tough question, right? I mean, it's everybody has different interests, and they don't really know what they really love, what they don't really love. until they go through all the different rotations. But for me, I've always said to the students, at least this is what drives me, I think, is that what you want to do is find what you really love doing and you go for it. The rest of the stuff will just fall in place. That's what I've said and I believe. So in that vein, I thought I should just share with you my journey, just being authentic and transparent about it. So I went to undergraduate school at Cornell, and I loved biology, so that was my major. I didn't know what I wanted to do with it. But I went to a missionary conference in my senior years at Cornell, and I was inspired, really inspired. I wanted to be a doctor because I wanted to go into missionary work. So I was already a senior. So back then it was kind of a gap year, unintentionally, but it was a gap year. I studied, I took the MCAT, and I got into medical school a week before class started. So I think that was wonderful. So then you go through your 4 years, and then of course the match, right? It's the day. And in my third or fourth year, I decided that I would pursue orthopedics as my specialty. I had a very influential resident that I rotated with. She was a female orthopedic resident. And I thought, wow, that's fantastic. I loved orthopedics. So I went ahead and did all the things that you needed to do, the electives, and then the interviews. I remember, at 9 different residencies that year, my senior year. And then, oops, the night before the match, I get called to the dean's office. It's never good news when you get called to the dean's office the night before match day. So I didn't get matched. I didn't match to any of the 9 places I interviewed for orthopedic surgery residency. So, we scrambled. There was another kid and myself, another medical student and myself, who didn't match. And they got me a surgical internship at Rhode Island Hospital in Brown University. So I was doing that internship, which started in July. And then in September of my internship year, I happened to be assigned to the emergency department. And it reminded me how much I really enjoyed emergency medicine rotation when I was in medical school. And I really decided, okay, this is what I really want to do. And fortunately, I rotated in September early enough, just when there were interviews going on for emergency medicine residency. So I was accepted to the Maricopa Medical Center emergency medicine residency. I was their second class, actually. They had just started the residency in 1988, and I was accepted to start in 1989. And so Maricopa Medical Center is where I did my residency, and now it's Creighton University residency. So this is the most recent graduating class. Look at them. So excited, brand new attendings in the class of 2022, right? This will make you laugh. So I started my residency there in 1989. Can you find me? Can anybody find me? Yeah, that's me, the young me. And then I graduated that residency in 1992. Can you find me? Look around. Ta-da, there I am. So that was almost 31 years ago. All right, so then, as I was thinking about this talk, there's like all these people, all these things out there in the internet that's painting a picture of what an emergency physician's like. There's some stereotypes. Some of it is actually quite on target. Some of it is quite true, like this Vicky Chan in the right lower corner there. But I thought, as I was thinking about how to share with you guys something that would be fun or interesting, I thought of 10 common characteristics. I'm sorry, here we go. I thought this would be a good topic to talk about and just to help you guys, which is the top 10 common characteristics of emergency physicians. I've seen and worked with so many through my long career that I thought this would be actually really helpful. And so for you guys, those of you who are undecided or undecided, let's go through these 10 common characteristics and you can sort of see if you match them or some of them or none of them. And they might help you decide what you really want to do with your life, with your career, because this is a marathon, right? Being a physician is a marathon. It's not just a sprint, right? So here you go. So number one, I think most ER doctors just really like variety at work and at life, right? Who doesn't like a variety pack, right? So emergency medicine, you see pediatrics, you see geriatrics, right? You see urgent care type stuff, stubbed toes. You see critical care, life-threatening, really sick people, resuscitations. You do see psychiatric patients because there's suicidal patients, there are psychotic patients, drug abuse and all that type of thing. You'll see some trauma depending on where you work, whether you're at a trauma center or more of a community center like I work at. So it's been said that emergency physicians are jack of all trades and masters of none. Well, we're masters at emergencies, but that's kind of the concept. So for instance, this is a tracking board, my tracking board, and you can see if you look through that, there's all sorts of ages, ranges. It's more seniors because I worked in a geriatrics ER, but there's all sorts of different chief complaints and types of symptomology here. Here's some examples. That looks kind of like it hurts, but you can put it back. That's a procedure. And then that, I can't hear you guys because you're all muted, but you certainly can guess at what that is probably. And you get to see intracranial hemorrhages like that. And sometimes you get to see gross things like that. These are maggots that I flicked off somebody's dirty wound, a homeless man's dirty wound. Now this, I don't know if you can see that. That round thing in the middle is actually a aortic aneurysm, abdominal aortic aneurysm. It's about 10 centimeters or so. This is a side view. And you can probably recognize that it's an arrhythmia of some sort, right? It's VTAC. You get to see that. I'll let you guys guess what that is. I'll tell you later if I remember to tell you. All right, so variety, that's number one. Number two, ER doctors generally like working with their hands. There's lots of procedures you do, like lacerations, you reduce joints, you do intubations, chest tube, you can do POCUS, bedside POCUS, you can incise and drain, and deliver babies every so often. Here is a couple procedures to show you.
Push down, push harder. Yeah, push harder. Yeah, you go 3 counter tracks. Okay.
Look at where the arrow is.
There, good. That's awesome. Yes. That is cool. That's too cool, right? Up, right? I know, dear. I know, dear. I'm sorry. Hang on. There's a piece of something right there. If I can get in here. I know, hon. I'm sorry. Could I grab her hand, please? Yeah, she's holding the baby. You can give her another 100. Another 100? Yeah, that's gonna be, it's soft, so it's gonna be hard to get to that. It's very soft. I know, I'm sorry, honey. Relax.
Look on the right. What is that? that's focus of an eyeball. That's a retinal detachment. And if you look on the left, you're probably wondering, what am I doing with my hands in this guy's mouth? But that is the position when you're trying to reduce a dislocated jaw. So yeah, people like to work, ER docs like to work with their hands. Number 3, now ER docs tend to be more extroverted, but or at least be highly functional introvert and are highly functional introverts. I mean, just because you're introvert, don't think that you cannot go into emergency medicine. I mean, in general, probably most are more extroverted, but I have definitely worked with introverted emergency physicians. They are able to, overcome some of that natural reticence and be really a terrific emergency physician and social introvert. All right. So if you've ever worked in an ER, and many of you have been scribes, you understand this. Most ER docs, everybody who works in the ER can handle distractions, right? It's like you get phone calls, you get families asking questions, and nurses are asking for clarification, orders, ancillary staff, the x-ray tech and lab people are calling to ask you this or that, something else. And then that's just the noise, the cacophony of the emergency with the patch phone, and then the phone calls, and then overhead calls. It's just really, can be really noisy, but ER doctors, ER nurses, staff just really handle that quite all that cacophony quite well. The really good ER doctors have sort of a learned or an uncanny inborn skill at being calm under pressure, or at least can fake it. I have said this many times. There are times in the past when I was still younger doc, and even recently actually, where I feel very nervous underneath the face, I guess, a surface. My legs will shake actually sometimes, but I try to sound and behave calmly, because you're the leader of the group under a pressurized situation, and your calmness will transmit down the line and will keep everybody more or less calmer. So then, these are the situations you would kind of have to be calm, if you will, during cardiac arrest, respiratory failure, hypoxic. The respiratory techs love to say, oh, these stats are dropping, they're 60, they're 50, septic shock, very aggressive, disruptive patients, and then hemorrhagic shock, they're hypotensive and they're losing blood, and being able to stay calm under that helps you manage the patient better. Now, this is just really one of my best cases, so I just want you to watch this. And this is a situation where so many things were kind of going wrong in the middle of this, but I was able to think through it and stay calm under it. But that's an important characteristic I think emergency physicians either already have or they must develop.
This is what the pre-hospital, can you see that? This is what the pre-hospital monitor EKG is. I don't know if you can, but I had a moment to look at the EKG. This is before he passed out, okay, or went into this sort of seizure-like activity. So we get him on the monitor really quickly on the bed, and this is what we see.
Oh, no, that's different. That's not at all what you just showed me.
I know. So we knew that something's changed, obviously, because clinically he's unconscious now. So CPR gets started. We see that his course refib, and we shock him, and you can see that on the monitor strip. So in the meantime, I intubate the guy during the CPR. He's in refib, so defibrillate him at 200. Nothing, right? So we do that actually 4 times in a row. And in the meantime, I've called out for Lido, Amio, Bicarb, just in case it's hyper-K, and calcium, right? So we are doing CPR. We are doing these defibrillations without any effect at all, right? So then I'm thinking to myself, my gosh, what? I'm thinking, I'm going through my head all the things that you had to do for refib. And I thought, dual pads. So that was like my thought. Okay, let's just try. So we slap on a second set of pads. I said to them, put the second pad in the front and in the back, and just let's try the 2 pads, right? So we shock him once. We shock him twice, nothing. We shock him 3 times, nothing. And I'm going, oh my God, what's going on, right? And so I actually go out to the hallway and I talk to the mom, elderly mom. I said, we've done everything I really don't know if there's anything more we can offer, right? So I go back into the room. At that time, one of the ED techs looks at the pad. He looks up at me and he goes, "Dr. Lee, is this pad here supposed to be in the back?" I'm like, "Yes." Like, what?
Oh no.
Yeah, right. So the tech changes that pad and puts it in the back. And now we're shocking him for the 8th time in total. And this is the 4th time of 400 joules. And we're roughly 22 minutes into it, 25 minutes into it. And we shock him. And I look on the monitor, and for the first time, I actually see a rhythm. I actually see this very slow Y complex rhythm. And I'm yelling, "Is there a pulse? Is there a pulse?" No pulse. So I'm like, okay, epinephrine, continue CPR. And we go another 2 minutes of CPR like they recommend, right? And ACLS.
Yep.
And now he's got a pulse and he's got a pressure. And we get an EKG and he's got an ST elevation STEMI.
Wow.
And then I call out the cardiologist who happened to be in the ER. So I show him this EKG. Yeah, exactly. I show him this EKG and he goes, "Oh, that's a STEMI." I said, "Yeah, we just."
I'm just showing it to you for your opinion. I didn't know. Tell me what.
So happy ending. After the stent, this is his EKG.
That's amazing.
I know.
And you had been out there talking to his mom about how nothing else was possible. And now you get to send her son home to her. That's amazing.
Right. It's not a shocking case. It's such an amazing.
Are you planning that fun for a few weeks? The shocking case fun?
Well, yes, no pun intended. But anyway, it is a shocking case. So then, long story short, or short story long, he actually left the hospital reportedly neurologically intact 2 weeks later.
Yeah, that was one of my best cases. Really miraculous. I was so really grateful that I could revive him. So number 6 common characteristic would be ER docs tend to have the ability to make critical decisions with incomplete information or data. You kind of have to feel comfortable with that. It may not be automatic as you start emergency medicine, but it's one of the things that kind of characterizes an emergency physicians, because you can't wait for all the info to come back in order for you to make a decision what to do. For instance, you've got a STEMI, you see it on the EKG, you don't have a trope, you have to call the cath lab or call the cardiologist. Somebody comes in hypotensive and they're shocky and they're like febrile. You have no idea where the infection is coming from, but you got to treat the patient, right? Same thing with respiratory failure. Someone who's hypoxic, really obtunded, really going down the tubes. You just got to rescue, intubate them. Hemorrhagic shock is a real common one that I feel really strongly. My personal practice is I transfuse them pretty early when I'm really convinced that they're bleeding somewhere, but I don't have a blood count back. I don't have the lab to show me how much blood he has, what his hemoglobin is. But I don't want to get behind the 8 ball with a hemorrhagic shock. Nursemaid's elbow is not so critical, but it is a subluxation of the elbow on a little toddler because somebody pulled on him or her. And you don't really need an x-ray if you're really convinced of that, and then you can just reduce it without an x-ray. Testicular torsion, same kind of idea where you make a clinical diagnosis and you can detorse the testicle and save the patient from ischemia of the testicle. Number 7, it's kind of like being able to handle distractions, but number 7, you develop the ability to multitask, and your decision making and patient care in the emergency department setting is really in parallel. Okay, not like internal medicine or family practice office where you see one patient, you get the labs, and then you wait for the labs to come back in 2 weeks or something, and you just sort of do your patient care sort of in tandem like that. Whereas in the ER, you're running multiple patients. And I just want to illustrate that a little bit just so you can understand. And you probably understand this if you've worked in the ER. So for instance, you pick a patient, 39-year-old patient, he's got chest pain. You go, okay, I'm going to order this, that, and that. The next patient you pick up a 72-year-old, nausea, started about an hour ago. You examine the patient, you order this, and that. And then you see this 84-year-old guy. He's coming in by ambulance. He's got blood in his urine. You decide, okay, let's check a urine IV for meds and all that. Next one, you see a 16-year-old. He's here with a headache and his back is hurting. So, you think, okay, I'm going to do oral meds maybe, or an IV med. I'll try, IV med. Then you see a 66-year-old, he's dizzy, he's confused, altered, with a headache. You ordered, this and that. So then you go along your shift, but then you get like, oh, I got my EKG lab and my monitor chest. It's not a STEMI, it's no problem, but he's at risk, so I'm going to put him in the hospital. And you go to the 84-year-old because everything's come back now. He's going to go home because the blended urine cleared, it's an infection, he's fine. And then a few minutes later, 72-year-old guy, he's nauseous. You've gotten all your tests back. He feels much better. He's going to go home, right? And then the 16-year-old headache, you gave him some IV Toradol. He's feeling fine. He's going to go home. Then the 66-year-old who's really confused, dizzy, you're like, okay, this guy is really not doing well. He sees he is negative, but he's not himself. He needs to come in for further tests. So you put him in the hospital. So the management of emergency patients is much more like this parallel situation, and you have to be able to multitask. Now, characteristic number 8, I think, is that generally ER docs are just flexible human beings, okay? You just have to be that way to live the kind of life that an emergency physician has, because there's lots of last minute changes, such as somebody's sick or whatnot. You got to cover them, or you have your own like surprise invitation to something and you really want to go. You ask your partners to make some changes or switch your shifts. At work, patient treatment changes depending on your data that you're getting from the lab or from scan or whatever. So you have to be willing to change your mind about what to do about a patient. Sorry. Then there's, slow days, there are fast days. And then in terms of the acuity, you could be looking at a stubbed toe 1 minute and then suddenly you're being called into a cardiac arrest by the charge nurse. So, you have to be really, really very flexible of a person. And then one other characteristic I find very common of the best ER doctors, they just have this uncanny ability to form a trusting relationship pretty quickly with the patient. They usually have good bedside manner. They can listen efficiently. They know how to politely sort of enter into a stream of consciousness conversation the patient sometimes have. And, not judgmental in terms of their treatment. Now, we all have biases. If we think we don't, we're lying to ourselves. We all have biases. But the key really is take those biases and put them on the side. Do not let those biases affect the way you treat your patient. So do not be judgmental. That's one of the things that I've noticed about a lot of really, really kind and good emergency physicians. Now, Jim Roberts is an emergency medicine icon. He had his own textbook, and I had a chance to do a couple of episodes with him. He passed away last year, but in one of his really great posts, he was talking about emergency medicine and talking to emergency residents, and he said, always be nice. And I would just say, do the best you can to be really nice. And you feel like you can't be really nice, at least be professional. I think that's the reality of things, because we can't always be 100% of the time really, really nice. And then one of the things that really is great about my colleagues and all the ER doc colleagues, that everybody has really pretty great sense of humor. But we kind of have to have a great sense of humor, because in order to get through this kind of a life as an emergency physician, where we are constantly seeing very sad, tragic situations, you kind of have to distance yourself a bit. Like we say things like, grandma didn't get watered, so grandma's got renal failure now, or grandpa got transferred to heaven. Or if you're taking handoffs from your colleagues and they're just handing you off a bunch of elderly who are waiting for a nursing home placement, they may say, oh, I'm just going to hand off this rock garden. It's kind of cruel, I guess, but it's really the way we handle the sadness of the situation. And then just face it. I mean, patients are ridiculous. And I'll tell you a story. I had a patient a few years ago that was brought in by these six muscular guys, medics, and he was tied down in the bed. And I walk into the room, and the firemen are outside, I walk into the room with my scribe, and the patient was just clearly psychotic. He was restrained all 4 points. And in fact, he had a net on his face because he was spinning. So like a dummy, I get too close to my patient. I've been told that. But anyway, I get down to the level of his face, and I was introducing myself, Dr. Alice Lee, how can I help you? What's going on? Why are you being this way? He heard me, and then he started saying, ching chong, chong chong, ching chong, chong chong. And I looked at my scribe, and I just laughed because it was just ridiculous how stupid this behavior was. But, you just have to get put up with this kind of thing, and you just sort of, you get through it. You just have to laugh at it. People are ridiculous, especially when they're on drugs. Now, I actually do want to say a few things to the ladies, slightly more pointed, I guess. I think that emergency medicine is a great specialty for women because of the flexibility. You never have to be on call. There's many women in this specialty, especially now. When I started, there was only 2 out of the 8 residents. The income is pretty high usually compared to other primary care specialties, and the stressors that you have, raising kids, being married, whatnot. The income really helps reduce those stressors by being able to go on vacation, state nights, housekeeping, daycare, those kind of things. But I have to, be honest, it's one of the more stressful specialties out there. The schedule is very irregular, and you work night shifts, which is horrible to me. I'm so glad I don't have to do them anymore. There's higher rates of divorce and suicide in the emergency medicine community than the general female population. And you miss a lot of family gatherings because you're working lots of holidays. 2/3 of your shifts are weekends or nights. And it can be physically exhausting. So I've definitely noticed that, recently, that it is more tiring for me physically to go through the shifts. All right. So I hope that those 10 characteristics help you kind of see if you're right for emergency medicine. Now, this is a trailer for Code Black. It was a movie that won the best documentary in the LA Film Festival in 2013. Earlier, we saw a little fictionalized bit of what emergency medicine is like. This is a bit more realistic, so I want you to take a look at this.
21-year-old male, multiple gunshot wounds to the left and right chest. Is that correct?
If you're an outsider, this looks like total chaos. But I see unity in that chaos. There's a team here coming together to save someone's life.
We're starting our senior year as ER doctors.
I had heard this was a very difficult place to train.
It's one of the most challenging places to work.
The gap between thinking and acting is minimal. There is so little tolerance for mistakes.
This isn't very good. What happened? During Code Black, it feels like the place is gonna blow up at the seams. I knew being a doctor anywhere else was not gonna cut it.
I knew that my life had to mean something.
My dad was diagnosed with Alzheimer's. I wanted to have the ability to help somebody who needed it.
It scares the hell out of you, and it makes you have to work hard, and there's no excuse.
Part of what we're trying to figure out is who we are.
The people in the emergency room were just different.
I really don't work out that much.
You're seeing people usually the worst day of their life, helping them cope with that moment. I don't expect that to ever get easy.
It really is just about doing the right thing for somebody.
When we started this, it seemed so simple. We were gonna help people. But as a doctor, the system is sometimes bigger than you.
It becomes this bucket of paperwork of saving somebody's life.
You work so hard, and all it takes is one thing to kind of topple it all down.
You have to ask yourself, how do I protect the ideals I came here for?
The crushing regulations on hospitals, they're tying your hands.
People that need help are turned away.
It's heartbreaking, soul-crushing, actually.
People leave because they can't wait anymore?
The doctors of this hospital believe we can do better.
Someone is suffering. What are you gonna do?
It's about these moments that are big, that are larger than life.
We're in a crisis situation.
I think those are pretty high stakes.
It's a team fighting to save someone's life.
Okay, so I'm in my 31st year in emergency medicine, and I have asked this question many, many times: was emergency medicine right for me? I would say unequivocally 100%. Yes, it was right. Every time I go to an emergency medicine conference, without exception, every time through my 31 years, I have always felt reinvigorated about my specialty. I've always felt I love what I do. I love the emergency medicine that I see. There's a lot of baloney you have to deal with outside of the medicine itself, but still really love the emergency medicine. Now, you guys are students. Would I encourage you to go into emergency medicine nowadays? It's very challenging these days. Definitely has changed in terms of the healthcare environment and the corporatization of medicine as compared to when I started and in my younger career. I would still say yes, but only if you really want to be an ER doctor. So I'm going back to the beginning. Medical students are always kind of wondering what specialty they should pursue. There's a few who know right away, and they've dreamed of being an ophthalmologist or dermatologist or chest surgeon and whatnot, and they won't be swayed from it. But most students still are sort of seeking, and they ask the question, is emergency medicine right for me? And I will always say, you have to find what you really enjoy doing, you really love doing, and you just have to go for it. The rest of the baloney, as I call it, will fall into place, and you'll find ways to deal with it. I really do love emergency medicine. I think it's a great service to humanity. I think that we are meeting people at oftentimes, the worst day of their life ever. And to be able to provide some tenderness and kindness and rescue them, I think is a great service to humanity. So I hope that with this little chat of the characteristics of ER docs, that it helps you maybe clarify some of your thoughts and your feelings. Maybe you match the 10, 8 out of 10, 6 out of 10, whatever. It helped really to clarify for you that thinking process of what should I be doing. In my case, I feel like it was a divine intervention that I was not matched for orthopedics, and I wound up going into emergency medicine. And I'm very happy that I was redirected, if you will. And I love being an emergency physician. So I hope this was helpful for you.